Great, thanks, Hubert. So good morning, everyone. Thanks for your patience. I apologize for the first version, which didn't go very well, so we'll give it another go. So I'm going to talk this morning about oncologic emergencies, of which there are lots, unfortunately. This is going to be more the structural version. So these are things that you can see on imaging primarily. So going to the next slide. We're going to talk about 4 different oncologic emergencies. So 1, SVC syndrome, pericardial tamponade, spinal cord compression, and brain metastases. And we'll go through each one of those individually. So we can go to the next slide. We're going to start with case. This is actually a real case. This is what I came up to Thanksgiving morning of this past fall. I was on call and got a call for a 56-year-old woman who actually had several weeks of throat soreness and fullness. She had been in and out of urgent care in the emergency room, had been treated for strep, then began having more shortness of breath to the point where she found it difficulty to walk from room to room in her house and was unable to care for her regular household activities. She had a cough, but described it as unchanged from her baseline. And then what really brought her to the emergency room was several days of face and neck swelling. So she presented with a classic case of SVC syndrome. Symptoms and signs are listed here. In parentheses, there's percentages of how often you see those, but based on a large retrospective series. So face and neck fullness is the classic symptom. Facial flushing can also be seen. Chest pain, shortness of breath is seen in more than half of patients. Headaches and confusion are concerning symptoms, but seen more rarely. On exam, what you'll see in terms of signs, face and neck swelling in the vast majority of patients, arm edema as well. Sometimes you can actually see venous distension on the chest wall. Stridor and hoarseness you can see more rarely, but again, really alarming symptoms that need prompt attention. Now, when you see SVC syndrome, the vast majority of cases are going to be malignant. So this is by far and away a diagnosis of cancer until proven otherwise. Rarely, some types of infection or after radiation, you can see some types of fibrosis that can cause it, but most cases are going to be cancer. Next slide. So this is a picture of a patient on the left-hand side. You can see the face and neck swelling. You can see how it almost distributes into her arms and that real fullness. And then on the right-hand side, there's a picture of her following treatment where she's back to her baseline. So you can see the stark difference there and the presentation of fullness. So in this picture, you can see in the background that venous distension in the chest wall. You can see that purplish discoloration that actually was seen in my patient. The facial fullness that's there. Those are pretty classic presentations. And then in the foreground, you can see the SVC emptying into the right atrium there. And that in this picture is blocked by the tumor. So then if you look above that, so all of the veins distal to that are engorged and enlarged, and that's where the facial swelling and things come. So that's the classic case of a mediastyle tumor pressing on the SVC and causing that venous distension. Next slide. So here you can see on CAT scan, on the left-hand side, that's a normal CT. You can see the superior vena cava there that's labeled. And you can see in the picture on the right, when there's a tumor in the mediastinum, how it can just obliterate and block the superior vena cava there. Next slide. So there's actually a formal grading system for SVC syndrome. I don't think this is used very often in clinical practice, but it can be instructive with the grade going from 0 to asymptomatic, 5 being fatal. It does give you a sense of what the urgency is to a particular presentation. Most patients presenting in the moderate category. So this, I think, is somewhat instructive, not necessarily used clinically, but does give you a sense of what the urgency is to the particular presentation. And when is it life-threatening? And when do you have some time to put together a reasonable treatment plan? Next slide. So what are the most common malignant causes? Lung cancer, unfortunately, makes up the majority of these cases, which makes sense. This is something that happens in the chest, with non-small cell lung cancer making up about half of the causes and small cell making up about a third. So small cell only represents about 15% of lung cancers, but it's disproportionately, causing SVC syndrome because it generally presents with bulky disease in the chest. Now, importantly, lymphoma is also an important consideration here, and that has implications for diagnosis and even initial management. So it's important to remember that that is on the differential list. Next slide. So how is it managed? So certainly supportive care is important and is going to be part of the initial management. So elevating the head of the bed, let gravity help you as much as possible. Steroids cautiously. I mentioned lymphoma is on the differential diagnosis list. So if you give steroids before a diagnosis is made, you can make that much more challenging for the pathologist because it can actually treat the lymphoma while you're trying to support the patient, making that diagnosis potentially more difficult. So in the case of my patient, given her smoking history, we were pretty sure it was lung cancer, but we held off on steroids until we knew that there was a biopsy taken and had spoken to the pathologist to make sure that they had enough tissue. We did subsequently start steroids, and it actually made a big difference. Now, in terms of supportive care, there's a very delicate fluid balance there. So sort of from the chest upwards, there's too much fluid. That fluid can't evacuate properly. But on the other hand, there may be decreased cardiac output, and you need to support the patient hemodynamically. So it can be very delicate. It requires sort of constant management and attention to not give too much fluid and worsen the edema that's up above, but support the patient overall. And then anticoagulation is an important consideration if there's thrombus. So these are patients by and large that have malignancy. This is a low flow state. So thrombus is fairly common, and anticoagulation is indicated in that case. So what about the sort of the general management? And that really depends on two things. The first crossroads is this life-threatening? If it's life-threatening, then the treatment is really needed urgently, and a stent placement is probably going to be the best bet. So engaging the vascular surgery team to go in and actually open up the SVC with a stent to restore flow and fix those symptoms in real time. If it's in more that moderate category that we talked about on that staging system, then it really depends on what type of tumor that we're dealing with. And you want to pick the management that's going to work the fastest. So for certain tumors, such as small cell, lymphomas, germ cell tumors, those are very chemosensitive. So starting with chemotherapy makes the most sense. In radiation-sensitive tumors, such as non-small cell, which is the majority again, radiation makes the most sense. Now, rarely, and maybe only in theory, would surgery be involved here. So occasionally, or it's been described that there may be thymomas that are pushing on the SVC that you'd want to manage surgically, but this is really the exception rather than the rule. So moving on to the next case, 65-year-old man with non-small cell lung cancer presents with shortness of breath and dizziness for several weeks. Vital signs show some tachycardia, blood pressure on the lower side, oxygen saturations that are borderline. When you look at him, he looks chronically ill and fatigued. He's tachycardic, lungs are clear, and he has some edema. So this is a diagnosis or a case of pericardial tamponade. And what are some of the ways you can make that diagnosis? Echo being one of the major ways, but you can also make it by EKG and chest x-ray, or at least give you some diagnostic clues there. So here's what a pericardial effusion would look like on chest x-ray. So you can see that the heart shadow or border is taking up much more of the chest than we're used to. And that's because in this case, that sac is filled with fluid. So next slide. Mainly the presenting symptoms are what you'd expect. So shortness of breath, fatigue, some chest discomfort, swelling can happen. If there's some backup if the cardiac output isn't where it should be, and presenting signs tachycardia is probably the most common. Hypotension is also seen. There's a triad called Beck's triad, which probably isn't the most common way, but a classic description of pericardial tamponade presentation that involves low blood pressure, distended neck veins, and muffled heart sounds. And then the classic pulsus paradoxus. So just as a reminder, it's a larger decrease in systolic blood pressure on inspiration, greater than 10 millimeters of mercury to make that pathologic. So that's how you could sort of be suspicious for based on symptoms and make some diagnosis, or at least spur further workup based on presenting signs. Next slide. So what does it look like on EKG? So on the left, you have the very dramatic presentation of electrical alternans. So you can see that the complexes are switched back and forth between a small and a large complex, and that would be an indication of pericardial tamponade. I think the more common, if anything is common in this particular presentation, is the low voltage in the limb leads. So you can see on the right side of the EKG, the complexes look fairly normal. On the left side, particularly small, and in contrast to the larger complexes. And how do you manage it? It's primarily drainage. And there are two ways that you can do that. One is as a procedure. The other is taking the patient to the operating room and doing a pericardial window. The drainage, the advantage is that it's less invasive. A catheter can be placed to continue the drainage if it's being constantly produced, for example, in malignancy, but it's significantly less invasive. But pericardial window, the advantage is if there's bleeding, if there's instability, the pericardial window can provide more definitive management. Also, if there's tissue that's needed, the pericardial window allows for a larger biopsy because you can actually get a biopsy of the pericardium itself. And an infection is considered to be indicated as well. Now, it's important to remember to always send cytology. This is important to confirm a diagnosis of malignancy, and also important to consider non-malignant causes. Many patients in this situation have had radiation. That is one cause of non-malignant pericardial effusion. And also important to remember that if it is malignant, this is usually part of a presentation of advanced cancer, and prognosis may be poor. Next slide. So here's a picture of the drainage procedure. This is the subxiphoid approach. So it goes right underneath the xiphoid process. You aim for the shoulder, and you can see the rim of fluid in this picture around there. Now, this is something certainly to be done in conjunction with your cardiology colleagues. I think there aren't many, this is something that's done infrequently, so really would need expertise in doing it, but that's what a subxiphoid approach would look like. And then the pericardial window. There are a number of approaches that the surgeon can take, depending, I think, on their own personal preference, but it involves actually opening up the pericardium. And this generally provides definitive management for tamponade. So moving on to the next case, 63-year-old woman with history of anemia, severe back pain for about a month, was given physical therapy and NSAIDs. They hadn't helped. She reports pain radiating to her lower chest, and she reports that she can't feel the ice pack that she places on that area for pain relief. So next slide. So this is a presentation of spinal cord compression. And as we all know, pain is nearly the universal symptom of presentation. It can be radicular in nature, as in our case. Also important to elicit a history of when the pain occurs. Pain with movement may indicate some spinal instability, and that's something that really needs to be vetted and assessed in this type of presentation. Weakness is also a potential presentation. Any neurologic symptoms, numbness, tingling, ataxia, urinary retention. And just a reminder that some spinal cord compression, particularly in the area of the cauda equina, can present with the syndrome of cauda equina syndrome. This involves bladder dysfunction, bowel incontinence, muscle and sensory weakness, and the classic saddle anesthesia, so inability to or loss of sensation in the area that would be covered if you sat on a saddle. So in that sort of perineal area. Next slide. So the initial assessment is really important here, making sure that there's spinal stability, a thorough assessment of the neurologic deficits. Imaging is going to be really important initially, MRI being the most helpful here, CT being important, but generally not showing the degree of detail that an MRI could. And then at some point, depending on the presentation and assessment of the remainder of the malignancy. Now, there is a differential diagnosis list here too, and important to remember that occasionally non-malignant causes can present like this. For example, an osteoporotic vertebral fracture if a bone has been displaced, infection and hematoma also presenting potentially with similar symptoms and signs, and with very different management. And imaging should be able to, particularly MRI imaging, should be able to differentiate those for you right off the bat. Other potential malignant causes to be aware of intramedullary metastases. So these present often with pain, but not always, and neurologic deficits. So just remember that you can actually get, metastatic disease within the spinal cord itself, which can cause similar presentation. Leptomeningeal disease spread similarly, and also malignant plexopathy. So cancer infiltrating into one of the major plexuses, either in the upper body or in the pelvis, which can cause both pain and neurologic deficits, and then radiation myelopathy. Next slide. So here it is in a picture, different cuts of imaging. The middle one probably shows it the best, where you have a cancer growing out of the vertebral body that unfortunately grows anterior, or that grows in a way that presses on the spinal cord and causes some swelling and compression of that area, and then subsequently neurologic compromise. Next slide. You can see it here in MRI form. At the top there, you can see that vertebral body has some enhancement there. It's irregular compared to the other vertebral bodies, and you can see the outgrowth that is then pressing on the spinal cord at the top of that picture. And how is it managed? So supportive. So if there is neurologic compromise or significant pain, steroids can be very helpful here. And there are lots of ways to give steroids. There's my sort of formula is dexamethasone 10 milligrams initially, and then 6 milligrams Q6, but primarily just because that's easy to remember. You could use somewhat less steroids than that. You don't want to use more than that, though. That's probably sufficient, at least initially, and then you can taper as the patient progresses, presumably with better pain control and better neurologic function. Pain control is really important here. DVT prophylaxis, so these patients are generally less mobile and have malignancy, so they're really a setup for thrombosis. So DVT prophylaxis is going to be important. And then physical therapy once they're stabilized to help folks regain their function. And then in terms of managing the spinal cord compression itself, it's primarily either surgically managed or managed with radiation. And it really depends on the presentation and the patient. So surgery tends to be better if there's spinal instability. Surgeons will be able to stabilize the spine. If there's significant neurologic compromise, surgery can sort of fix the lesion faster and hopefully restore that neurologic function. If there's prior radiation, that favors a surgical approach because the amount of radiation that the patient could get is going to be more limited. And then in radio-resistant tumors, so in tumors that don't respond very well to radiation, surgery may be a better option. On the other hand, radiation is better if the tumors are radio-sensitive. If there are multiple areas of disease, the radiation is going to be able to manage that better. If there are multiple areas, the surgery is not likely going to be able to address all of those areas, whereas radiation has a better ability to do that. Radiation is also going to be better in patients who have really compromised health or performance status. It's just going to be better tolerated than surgery would be. And also going to be better in patients that have significant burden of systemic disease, because they're going to be able to get back to their systemic treatment faster after radiation versus recovering from surgery. So both considered very good management options, but each have their advantages and disadvantages. So moving on to the next case, 72-year-old man with history of small cell lung cancer. His wife reports that he has been confused at home, difficulty handling the bills, which he always handled before. He's actually fallen at home. And when asked, he reports that his headaches are different than his prior migraines and worse when he's bending down to tie his shoes. Next slide. So here's just a picture representation of brain mets by imaging. You can see on the left hand, the lesions, there are multiple of them that disrupt the brain, parenchyma there. On the next slide, you can see that some of those areas are enhancing. So just to see what it looks like by imaging. Next slide. So most brain tumors are actually metastatic lesions. What are the cancers that most commonly spread to the brain? Lung, unfortunately, is one of them. Melanoma, renal cell, breast, and colorectal cancer, with lung cancer doing it most commonly. Now, these are felt to be increasing in frequency, probably because people are living longer. We have better systemic therapies, so people are living longer. But unfortunately, many of those systemic therapies are blocked by the blood-brain barrier. And it tends to be an area that's spared the systemic therapy and can be an area where metastatic lesions can develop, even if systemic disease is controlled. So another picture of a brain lesion. I think this picture, you can see a little more of the swelling which surrounds some of the areas, which depends on what, this is in the lower right half of each of these pictures. And you can see the significant edema in different contrast settings. Symptoms, primarily headache. They can be postural, as in our case. The sort of waking up with a headache, the morning headache is classic, but actually uncommon when you look at series that look at presenting symptoms. The other potential symptoms, weakness, sensory loss, forgetfulness, seizures, nausea and vomiting if there's increased intracranial pressure, and sometimes stroke-like symptoms. Next slide. So it's important to first assess the neurologic deficits, so you know what you're up against. And then imaging is really the most important first step, with MRI being the most helpful. It's going to pick up it'll give you the most thorough assessment of what the brain disease is. Contrast CT is a second choice, followed by non-contrast CT, which generally misses many small lesions. So it's only going to pick up the really large lesions or ones that are causing significant swelling or damage. And then at some point, depending on the presentation, an assessment of the remainder of the malignancy. Management, similar to spinal cord compression, steroids, if there's neurologic compromise or edema on imaging. I use the same formula. Again, a little less is okay, more is probably not needed. Similarly, these are patients that have malignancy, so DVT prophylaxis is going to be important. And then physical therapy to help restore function once the patient is stabilized and managed. So another picture, you can see this is a very large, this one, ring enhancing brain lesion. This, you can see the edema surrounding the lesion in much more detail and clearly. So presumably this would be causing significant neurologic compromise. And the management is also either surgery or radiation, with each having their own disadvantages and advantages. So in patients that present with a single brain metastasis, surgery is often a better modality. It's also helpful, surgery is also helpful in cases where pathology is uncertain or needed. Better managed in someone who has a good performance status, they'll be able to get through surgery a little bit better, and is often followed up with post-op radiation. Now, radiation is probably the most common way that brain metastases are managed. It used to be that whole brain radiation was the only sort of tool in the toolbox for the radiation oncologist, but the advent of stereotactic radiosurgery with really focused radiation to individual lesions has been a great advance in the radiation world. So generally, the field is moving away from whole brain and using this, very focused stereotactic radiosurgery. Now, there's a bit of a balance there. So if only individual lesions are treated, that leaves the remainder of the brain, which is obviously at risk for additional lesions at risk. However, whole brain radiation can be quite toxic. So there's a risk of, acute toxicity, long-term toxicity, neurocognitive loss over time. So there is, using stereotactic radiosurgery can really decrease that risk over time. So most patients are treated with stereotactic radiosurgery if they have up to 10 brain lesions, and that's really the preferred method because of toxicity. And generally speaking, steroids are continued through at least most of the course of radiation and then tapered off after that, but you can get some acute edema during radiation. So the steroids can be helpful even during the radiation course itself. Now, in very select cases, you could use systemic therapy. And again, this is really in very select cases in select tumors. And there are really two examples here where it can be helpful. And this is instead of surgery or radiation. In melanoma, in patients who have very small and minimally or asymptomatic brain lesions, the combination checkpoint inhibitor therapy can be used to manage brain mets. There is some, there is some spread to the brain for both of those therapies, so they can treat those particular brain lesions with immune checkpoint inhibitor therapy. And then in the world of mutation-driven lung cancer, there's a movement towards using the targeted agents to treat the brain lesions. Again, in folks that have small or minimally symptomatic brain lesions, or even moderately symptomatic brain lesions, the targeted agents can work very well to control those lesions. So you can see osimertinib here. I've listed a 91% intracranial response rate, which is excellent. Alectinib, which is used in the ALK-driven lung cancers, has an 81% intracranial response rate. So some of those folks can be spared radiation altogether, or at least for a period of time using systemic therapies. Great, so those are the 4 areas of structural emergencies. Be happy to hear some discussion and questions.
I have a question for the Haiti team. Have you experienced any of these emergencies that Liz mentioned, and how have you guys approached them? Because I know some things are not entirely available. So like, how do you sort of approach some of these things, or how have you in the past?
You guys are on mute.
It's back in mute again. Oh yeah.
Sometimes we see patient with heartache. We used to have patient with breast cancer after a long time of chemotherapy presenting with headache sometimes, and sometimes they can perform cerebral scanner, and at this time we can confirm brain metastatic syndrome. So as soon as we see this patient, we used to switch them on palliative care.
Have you, other than brain metastasis, have you seen any of the other ones, pericardial effusion or cord compression, or any of the other ones?
Rarely we have this case. For me, never. I never seen this case.
And any of the other folks?
Is Dr. Lermil back?
Not yet.
Not yet.
I know there was, we've definitely had cases of pericardial maybe not frank tamponade, but we've definitely had cases of large pericardial effusions, as well as cord compression over the years. So these might have been patients who presented prior to the new team starting, but just wondering, how these things can be diagnosed what would be the steps? And this is sort of for the team to sort of think about, like when you run into situations where you suspect these things, what would be the steps that you would take diagnostically, just given the challenges of what's available locally at HUM. So I don't know if any of you have any comments or thoughts on that. You're on mute.
Wait a second. I'm trying to translate. Not commonly. We used to check patient for brain metastatic lesions, but not commonly for pericardial tamponade or others. Sometimes we used to have patients with symptoms like spinal cord compression, and then we usually switch them on neurology for consultation, and sometimes we switch them on palliative care.
And these are diagnosed by CAT scan primarily?
We do not perform CAT scan in Haiti. Sometimes we only have a CT scan.
Mm-hmm.
Yeah, so CAT scan and CT scan mean the same thing. I guess, yeah.
And how much surgical support do you have? For example, if you had a known spinal cord compression, would there be a surgeon there that would be willing to decompress that or stabilize the spine?
We have surgical team, but I don't know if they used to perform this intervention for the patient yet. I don't know yet.
So you have I know there's definitely a neurology team. And is there a neurosurgical team that is there all the time? Or is there like a team that comes sometimes and not other times?
Sometimes when we have this patient, we used to discuss to them, and they still have some limitation to perform those intervention.
Okay. And do you have like cardiologists or, so for example, if somebody required some sort of say, a tap of the pericardial area or a drain, is there like a cardiologist or cardiothoracic surgeon who helps with that, or is that usually done by the other generalists?
Yes, we have in internal medicine, we have a cardiologist. He used to perform sometimes rarely some surgical drainage for pericardial tamponade. Not usually. It's rarely cases we need to perform this intervention.
I don't know if anybody does it commonly, but
the other question I had for the team is how can you guys get regular EKGs on patients routinely? Like how challenging is it to do that?
Yes, we do. Sometimes sometimes we only have electrical sometimes only on EKG we can maybe confirm that patient had some pericardial invasion or on oncology.
Mhm. And do you have a way of saving the EKGs or tracking the EKGs over
Yes,
time?
on EKG, sometimes when we had muffled heart sound, and when we had hypotension, and rarely vein distension. Sometimes we do perform EKG and we can confirm microvoltage, and that sometimes we used to think about pericardial tamponade. And rarely we perform in internal medicine drainage. Sometimes it's the surgical or emergency team that perform this intervention.
Are you able to get an ultrasound, an echocardiogram of the heart?
Yes,
urgently?
we do.
Yeah.
We do perform. Usually we do exposure.
I think the
So-
muffled heart sounds and the hypotension is a pretty advanced presentation. I find it's probably something that should be thought about or put on the list of sort of unexplained shortness of breath or particular fatigue in a patient, particularly if they've got chest-based cancer.
Can you repeat, please?
Liz, can you repeat that?
Sure. Yeah. So I think the muffled heart sounds and the hypotension, tends to present if the pericardial tamponade is very bad. So I think to catch it earlier, it's probably should be on the list of diagnoses that you're thinking about when you have a patient presenting with unexplained shortness of breath or particular fatigue that's new or different.
Yeah. Yes, we usually we perform cardiac sonogram when patient presenting on physical examination with shortness of breath or muffled heart sound.
Mhm.
Yes, we do perform usually cardiac ultrasound sonogram.
Scott, I don't know if you're on the call. A lot of this is managed with radiation. Anything that you'd want to add? I know it's not something you guys have access to, but is really a mainstay of treatment.
Yeah, no, it's very frustrating not having radiotherapy because so many of these emergencies that you discussed, including SVC, spinal cord and brain metastasis, can be effectively palliated very quickly with relatively short and uncomplicated treatments on the radiotherapy end. I have to say that, there are certain things that you could treat with chemotherapy. There are certain situations where it may be helpful, but just in terms of reversing some of these issues quickly, radiotherapy is really the treatment of choice often for, whether we're talking spinal cord compression or SVC. And brain metastasis, less so in terms of in an emergency situation. In an emergency situation, often it comes to surgery first with radiotherapy to follow.
Okay, great. Any other questions from the Haiti team or discussion from the group?
Another situation, I see all over the presentation, you do not talk about Lee's tumor syndrome. How about Lee's tumor syndrome?
Tumor lysis, is that right?
Yes.
Yeah, so I think that the oncologic emergency series is ongoing. So I think more to come. Am I right, Dio?
Yes, yes. So there are lots of emergencies. So we decided to break it up into structural versus other emergencies. So the other ones, I'm supposed to give a lecture on those at some point, but we'll work on the date. So there are other things like, as you mentioned, hemolysis syndrome, other types of electrolyte abnormalities, other types of hormonal imbalances. So
Septic shock.
yeah, shock, adrenal insufficiency, things like that. So there are a lot of different ones. So we were just trying to pick out whichever ones were most serious and which ones that were you could also do something about in some ways in Haiti. So more to come.
Okay, thank you.
Finally, we can say in Haiti, it's very difficult to take care of this question of the complication of cancer because we don't have radiation. Because the lecture we can say all the complication we have, the treatment sometimes is radiation. There is radiation in the treatment, but in Haiti we don't have the possibility to do radiation. We don't have the possibility to do MRI. Yeah, and even surgery we cannot perform the some the resection of some tumor. That's very difficult for our patient. And as question, I have a question. What can we do, for example, with a patient on palliative taxol that present with loss, sensory loss, but we don't have the possibility to perform MRI, but this patient is on palliative taxol, and we know that taxol can give sensory loss.
Sure. That's a really good question because there's some overlapping presentation there. I think, an assessment of pain is going to be really important here because, Taxol may present with diffuse sort of aches and pains, but wouldn't have, so for example, an area of focal back pain that would make you think of spinal cord compression. And an assessment of their neurologic status. So if they've got motor weakness, if there's some atypical nature to the way the sensory is presenting, one side greater than the other, for example, or in an area that's atypical. So with Taxol, you'd expect it to start on the tips of the fingers and toes and work its way upwards. So if a presentation is different than that, then it may make you think more of a neurologic compromise. But I think in the case where you're not sure that it's typical for Taxol, even a CAT scan will be helpful to see what's going on in that particular spinal level.
Thank you.
If you're able to get it.
Thank you.
I have a question. Hello, everyone. I'm a resident, actually in the oncology rotation. I have a question. If, for example, because in Haiti we don't have radiation and we do not have some types of surgery. If, for example, a patient is presenting with superior vena cava syndrome, we do give him steroids. Do we always have to go to the surgery, or do we always have to do some radiation? Because in Haiti we don't have this opportunity. The question is, can we simply give them steroids and then see how the symptoms will progress?
Sure. Yeah. So that's a great question. Without radiation, what are the tools that you have? And I think trying chemotherapy so initially I think steroids are reasonable, with the caveat that I mentioned that if you haven't done the biopsy yet and there's a possibility of lymphoma, you may decrease the yield of that biopsy. So it's important to get the tissue first if you can, before going ahead with steroids. But steroids can provide some temporary relief or improvement. It won't fix it or resolve it, but it can cause at least some symptom relief. And then if the only tool you have is chemotherapy, it's worth trying in a patient who has an otherwise good performance status. Just that chemotherapy doesn't have the response rates that radiation does, particularly in non-small cell lung cancer. So the chances of a response are significantly less. But in the case of lymphoma or small cell, chemotherapy really would be the treatment of choice anyway.
Okay, thank you.
Okay, great. Well, certainly reach out if you have other questions. You're welcome to have access to the slides and take a look at the pictures in a little more detail. And I'm glad it worked the second time around.
Thank you, Liz.
Thanks, Liz. Great talk.
Okay, take care, everyone.
Thank you
Thanks,
very much.
everyone.
Thank you all.